Cassie Jackson. I would like to thank INHWE for allowing me to present my research via recording on interprofessional education, determining an optimal time to begin IPE curriculum. I also want to thank my mentor, Dr. Kosmenko. Prior to medical school, I worked as a patient care technician, and this is where I started to see the dynamics of a healthcare team unfold, the good, the bad, and the ugly. There were many flaws in communication and execution, and personally, I saw this only affecting one person, the patient. It was the patient who was put at risk for complications. It was the patient who was suffering in pain. It was the patient whose healing was prolonged. All of these things were because of lack of interprofessional teamwork and communication. It wasn't one individual's fault, but the shortcomings of inexperience and a lack of education on how to properly utilize each team member to their fullest potential. After starting medical school, I was presented with the opportunity for research in strengthening healthcare interprofessional education, and after my firsthand experiences, I knew this was important to find the best time to begin exposure and implementation of IPE to ensure students are receptive and engaged. Greatly improving IPE curriculum will only better the healthcare system for our patients. This project has been divided into two parts. The first part, published in 2017, explored attitudes of only medical students at the University of South Dakota Sanford School of Medicine. We are currently working on the second portion. The second part surveyed many different healthcare specialties at institutions worldwide. The respondents encompass 8 healthcare professional programs across 11 countries in Europe and North America. It is important to ensure each healthcare program is implementing IPE at a point within their curriculum that ensures positive results for each contributing team member. We also wanted to explore if cultural variations would need to be accounted for in providing recommendations for IPE implementation. Today, I am presenting on data gathered from 5 healthcare professional programs at the University of South Dakota. These programs include nursing, medical doctorate, physical therapy, occupational therapy, and physician assistant. Our global data is currently still being analyzed. Aside from my personal experience, this project is necessary due to modern healthcare trending toward multidisciplinary, team-based systems that emphasize patient-centered care versus problem-focused. This results in higher quality of care, decreased length of stay, lower costs, and fewer errors. This project used the World Health Organization's definition of interprofessional education as occurring when 2 or more professions learn with, from, and about one another to improve collaboration and quality of care. The goal of this survey was to gain insight from students. How they perceive their IPE activities is important, not only to introduce IPE at the appropriate time, but utilizing an educational style that suits the students' attitudes at that point in their curriculum. First, overall attitudes toward IPE were assessed. Attempting to implement IPE when overall opinions are negative could be counterproductive. It is crucial to have a positive foundation that instigates further growth and teamwork. Just as it is important to do cardioversion on a synchronized basis, this is the same concept. We need to make sure that IPE is implemented at the exact moment that it will have the greatest effect. Individual professional competency is necessary and expected in IPE. Therefore, attitudes were targeted on readiness to teach and learn, to assess when one feels comfortable teaching about their own professional role, and when they feel confident in their curriculum of basic science and clinical knowledge to start learning from other healthcare professionals. Accompanying readiness is an individual's role clarity in their profession and their prospective team member. Role clarity is understanding your scope of practice to know where your job begins and when to utilize another member of the team. Currently, interprofessional training is not a graduation requirement, but programs are moving towards implementing guidelines to support recommendations of the Institute of Medicine that are trying to address the World Health Organization's desire to strengthen IPE in hopes of diminishing the worldwide health workforce crisis. A survey was developed to be distributed to many different healthcare specialties globally. Data gathered included demographics, type of healthcare program, and student attitudes. Demographics include location of medical school and program stage. The location of the medical school allows cultural comparisons of attitudes. The survey was translated to 8 different languages to prevent the language barrier affecting results. Identifying program stage will help pinpoint ideal time to introduce IPE activities. Programs targeted in this USD dataset were medical doctorate, nursing, physician assistant, physical therapy, and occupational therapy. Other programs like respiratory therapy, social work, and pharmacy were surveyed but yielded low response rates within the USD population and were not included. Student attitudes were assessed on a 27-item academic interprofessional education attitude scale, scored with a Likert 4-point scale. I will now go over the results from the USD dataset. In each of these graphs, the blue line represents medical students, the red line for nursing students, and the gray is the combination of our 3 smaller programs, PA, PT, and OT programs. Average attitude scores from the 4-point Likert scale are displayed on the vertical axis, and the curriculum stage progresses along the horizontal axis from beginning to graduation in quarter divisions. This particular graph displays overall IPE attitude scores. Attitudes were high in the beginning of each curricula, declined towards the middle to 3/4 of the through, and increased towards graduation time. At the time of graduation, nursing students had the highest interest toward IPE among tested specialties. Data collected on readiness to teach and learn had similar trends of increasing throughout the curriculum. Here is attitudes towards their ability to teach other professional healthcare programs. As you can see, there is a positive trend from the beginning of each program to graduation. Here's the attitudes towards ability to learn from other specialties that would be seen in an ideal interprofessional team. Again, there's a positive trend from the beginning to graduation for each program. Professional identity is defined as one's professional self-concept based on attitudes, beliefs, values, motives, and experiences. Here, medical students' professional identity increased throughout the curriculum. There's a rapid incline during the start of the clinical rotations, as you can see right here. Nursing and PT, OT, PA students' professional identity was high at the beginning, then rapidly declined during the first quarter of the program's curriculum, and then increased until graduation. Knowledge of the professional roles is understanding where your role ends and your team members begins. It is important to have defined roles to ensure each member is an expert and efficient in their duties. Students initially all had uniformly positive comprehension of professional roles across all the programs, then decreased at the middle to 3/4, then finished with a positive trend amongst corresponding cohorts. At the time of graduation, nursing students' knowledge of other healthcare professional roles was lowest, as seen right here. From this data gathered at USD, we have concluded that attitudes towards IPE are highest at the beginning and at the end of their respective curricula. Lack of IPE at the beginning of each program is a missed opportunity. Each introduction of IPE might prevent the loss of interest in the middle of each curriculum and allow for more opportunities to integrate IPE activities. Just as I had said before, when you're doing a cardio version, a synchronized cardio version, you need it to be at the exact moment. By not doing it early enough, we're having a missed opportunity to successfully convert a patient, or in this opportunity, or in this situation, a missed opportunity for successfully implementing IPE. We also concluded that degree of professional identity development does not seem to correlate with overall attitudes towards interprofessional education, that IPE activities at the end of the programs are likely to be well received and informative for students in all of the healthcare professions. IPE activities administered in the middle of the curriculums could be counterproductive. Just like if you don't synchronize a patient at the exact moment you need to, you could cause more damage than good in converting that patient. Currently, USD has utilized this data and instituted an interprofessional intensive care unit rounding simulation within their curriculum, integrating all professional healthcare programs at their institution. We hope to conclude the rest of our data analysis soon to help guide recommendations for globally instituting and requiring interprofessional education around the world. Here are some of the references utilized within this presentation. And if you have any questions after this presentation has been taken from live questions, you can contact me at cassie.jackson@coyotes.usd.edu, and I would gladly start up any conversation with any interested. Thank you very much. I greatly appreciate the opportunity to present to all of you on this very important topic.